It's the first time in the world we've heard these 3-year data from Syntax 2. It's very exciting for us as investigators, hopefully for you as an audience to hear these data. First in the world, presentation of 3-year outcome data from Syntax 2.
Thank you, Adrian. So you see the pictures of Adrian and Gabi Escanet. They were the 2 PI of this trial. This is a trial was generated by 2 companies, Volcano, which is now Philips, and Boston Scientific at the time of Keith Dawkins and Michel Lussier. So the time is passing by, but Adrian and Gabi did a wonderful job. This is my conflict of interest. It's clear, it has been explained by Escanet, that there's been many changes since the Syntax 1 trial. We have this new risk stratification tool, the Syntax Score 2, which incorporate the clinical and the anatomical variable to guide the heart team and to give you a mortality at 4 years if you go to surgery or if you go to PCI. Certainly the physiology-based revascularization, at that time it was still the hybrid use of IFR and FFR, a second generation of DES, that's the synergy, certainly finished the job with the IVUS to optimize the stent deployment using the music trial, something created by Antonio Colombo more than 30 years ago, and then have in the team an expert dedicated to CTO who would do the good job and we'd be there on the day of the case, plus all the goodies of the medical treatment, pharmacological treatment. So it was, I have to remind you, a multicenter, prospective, but single arm. It was between randomized trial. We were coming out of the Syntax 1. We get engaged in the Excel. It was a little bit too early for everybody to get engaged in a new challenge, not to say battle. So it's a single-arm, open-label trial, patient with de novo 3VD, 3-vessel disease without left main involvement. But the inclusion was smart. The inclusion was using the Syntax Score 2, so not only the anatomic Syntax Score, but also the left main, age, creatinine clearance, ejection fraction, gender, COPD, which is very bad for the surgeon, and peripheral vascular disease. And that Syntax Score 2 recommended for one patient either CABG or PCI or equipoise. You can go both ways, and most of the time the patient select a PCI. And that PCI based on Syntax 2 is irrespective of the anatomic Syntax Score 3-vessel 22-23. So we opened the door again by using the Syntax Score 2. It was a long discussion with Keith Dawkins at that time. Sample size, 450 patients, 90% power to show superiority at 1 year in terms of use of the second generation of synergy. So the primary endpoint is what we call the patient-oriented composite endpoint. It's all-cause death, any stroke, any MI, and any revascularization, easy to adjudicate now at 3 years follow-up. And it was, of course, adjudicated using the same criteria of Syntax 1 so that we had a fair comparison. For instance, CKMB 5 times with a Q-wave was the robust, clinical, relevant criteria for myocardial infarction. And then we were picking in the Syntax 1 a predefined cohort of patients, 315, from the original Syntax 1, selected on the basis of equipoise 4 years mortality between CABG and PCI. So in the larger pool of patients, 1,700 of Syntax 1, we took exactly the same patient with the same Syntax 2. If you are below 0.86, you have to do an angioplasty, you have to implant the stent, and as you could see, it was done in 99.5% of these patients with an IFR below 0.86. Then at that time, after Advice 1 and Advice 2, there was what we call the gray zone between 86 and 93. And then you were allowed to do an FFR, and it was done in 94% of these cases in the gray zone. And basically, 2/3 of these patients were treated, 67.8%. And then you have the IFR above 0.93, which represent 24% of the patient, and then 92.6%, according to that parameter, was deferred. As you could see, only in a small cohort of 27 patients, FFR alone was done. So what is interesting in this slide is that you start with 1,559 lesions, 3.9 per patient, and you end up with 2.64. So you have that reduction of the work to be done based on physiology. Now, if you talk a little bit about the improvement syntax 1, syntax 2, what is remarkable is that the physiology was, of course, performed in syntax 2, and you see the type 31% of the lesion were deferred based on physiology. So basically, I talk about the 349, but that was already at the time of the heart team. But as a matter of fact, just looking at the plane and geography, in syntax 1, there was 4 lesions treated, and in the syntax 2, 2.64, so much less lesion treated due to the physiology. And if 83.3% of the disease was classified as a 3-vessel disease and remained a 3-vessel disease at treatment, in the case of syntax 2, it became 37.2. If you look at the success rate of the CTO, we had the expert in the room. It's a very acceptable 87% success rate of CTO. It used to be 53% in syntax 1, major improvement. And then in terms of IVUS per patient level, 84%, or IVUS per lesion, 76%. Per patient, 84%. They were basically no IVUS in the syntax 1. Today, the follow-up is well reasonable, 97.3 and 97.1. You know that I'm obsessed by the vital status, and I look for the vital status until the very end. But seeing that in syntax 1 there is 9 patients, I'm not going to chase these 8 patients too much. This is the primary endpoint that you have seen at 2 years. You know that in many of these trials, Excel also, but certainly syntax, ARTS 1, ARTS 2, there is a moment where the curve crosses. Now, here we are not talking about surgery, we are talking about PCI syntax 1 and PCI syntax 2. This was the curve at 2 years, and the curve at 3 years are like this. So we have in syntax 2 a MACE rate of patient-oriented composite endpoint of 17.2 versus 26.7 in the syntax 1. That's a risk reduction versus syntax 1 of 40%, highly significant. Where is that coming from? It's coming a little bit from all-cause death, 7.7 in syntax 1, 5.2 in the syntax 2, a little bit from the stroke, 2.4 in the syntax 1, 1.4 in the syntax 2. There was certainly an issue with early myocardial infarction in syntax 1, so 6.8 and 2.3 but it's driven, of course, the MACE is driven by the any repeat revascularization, 11.8 at 3 years versus 17.5. That's a p-value of 0.06, 0.026, sorry, and it's a risk reduction of 35%. If you look at definite stent thrombose, the news are also very good, 0.9%. That's quite amazing after 3 years for multivessel disease versus 3.3, and even that reach a p-value of 0.028 and potentially a risk reduction of 73%. Now, this is at the core lab. They analyze very, very carefully all these coronary angiogram. Basically, there is a paper, I think, in JACC on the QFR of all these lesions to show that we do a good job also, not only with the pressure wire, but also with the angiography. And as you could see, all revascularization from 2 years to 3 years, there is in total 12 lesion which has been treated out of the initial 1559, and that in 10 patients. And what you see that between 1 and 2 years, we had 2 TVR non-TLR, we had 3 non-TVR deferred, but the TLR in the stent, due to the restenosis of the stent, was just 77%. Now, if you look between 2 years and 3 years, and the things get stabilized, we have only 1 TVR non-TLR, we have 3 non-TVR in de novo lesion, we have 3 non-TVR in deferred lesion, but nothing dramatic. The patient came back for angina, the lesion has a progress, it was a deferred, and it was treated, and then another 5 TLR treatment of the stent lesion. Now, I'm finishing by showing what happens potentially versus surgery. You remember that we create these kind of propensity by syntax score 2. So we were really pleased to see at 3 years that surgery in syntax 1 was comparable with syntax 2, but I was expecting already somewhere here the cost point, and we go to 3 years and there is no cost point. Surgery is there with a good 19.3%, and we are here with the syntax 2, 17.2%. 2 more slides, which are very important and personally puzzling me, really. It is going to create a new research. The good news, of course, is that with this selection by the syntax score 2, the old anatomic syntax score doesn't play anymore, because you could see here that the patient with a syntax score greater than 22 of less than 22 have basically the same outcome, 18.8 and 16.4. The big puzzling things is that you have here 136 diabetic. I agree, it has to be, we have to introduce some granularity about diet, hypoglycemic drug, and insulino-dependent, but nevertheless, we have there a patient who has been classified by the investigator has a diabetic, 136, and 318 non-diabetic, and I'm puzzled by the fact that they end up almost on the same line, 18.6 and 16.6.